What's going on, guys? Sorry that I could not be there today, but we're going to go over some pretty important stuff. We're going to do chapter 3 and chapter 6 today. So let me go ahead and get this rolling. All right, so chapter 3 is all about public policy and aging, how that affects aging, the process of aging, and your patients that are, your different stages of young, old, middle, old, and old. Um, let's jump into it here. So, public policy reflects society's values and beliefs. This kind of stuff has changed, as you can see throughout history, how we've become, more open to different types of care for the elderly population as we're getting a more diverse and older population. We're having people living much longer in life. So, that kind of reflects with how public policy has changed. In most developed countries, there's some form of universal health coverage. In the United States, there are three big ones for, elderly populations. No, there's no universal health care coverage everyone in the United States, but the three big ones to remember here are the two big ones are Medicare and Medicaid. And then we're going to talk a little bit about the Older Americans Act. The first one I want to talk about is Medicare. It was enacted in 1965. It is paid in part by worker and employer contributions, and some are paid by insurance type premiums. Like you can get different types of Medicare, like Medicare Advantage plans. I know you guys have heard that online before, stuff like that. Universal coverage is kind of the big thing with Medicare for those people that are over 65 years old and people with disabilities. So it's not just, people over 65. You can also get Medicare coverage if you have a disability. There's four different types. These are very important to know for exams and for practice. So Part A is your hospitalization, skilled nursing home care that is like short-term kind of skilled nursing home. Home health care and hospice is all Part A people. Part B, Medicare is physician and other healthcare providers. Also, Part B is long-term care for skilled nursing facilities. Part C is Medicare Advantage plans. Is kind of what I was talking about a second ago, like you're, in part by insurance types. These are additional things that you can get. And then Part D is strictly prescription medication. So, what do we care about with therapy? Medicare is a primary source of payment for older adults. This is why when I talked about, if there's ever any cuts in Medicare or changes in payment for Medicare, everyone explodes. The reason is because it is the largest payer for older adults and therapy. Items in Part A, B, and C are all relevant to OT and PT coverage, so keep that in mind. You may have a patient's Part A, Part B. If you go back to those Part C people, that's the Medicare Advantage plans. So, that definitely you can have a patient who is Part C or is billing some off Part C. All right, so Medicaid. Medicaid was acted, shortly after Medicare. It was in 1966. This is coverage for, people of any age. Anybody can be on Medicaid. It also covers some long-term care for older adults. There's a lot of stipulations. We'll talk about these, and I want to talk about these more when we're in person again. But there's a lot that goes into qualifying for Medicaid. The biggest thing is income. You can't go over a certain amount in income. It's pretty low. We'll check those numbers in person when it's not much. I think it's like $1,000 or $1,300 a month. Don't quote me on that, but we'll check it out for sure. And that changes every year. They reenact, do this and change what the qualifications are for Medicaid. It's something I have to constantly reapply for. So yeah, that's one of the bigger insurances you're going to deal with in West Virginia. So you have the Older Americans Act. This was in 1965. It covers a variety of community services for older adults. Senior meal programs. There's different area agencies on aging, like there's the Canal City Commission on Aging, those kind of things. That all was established with this Older Americans Act. You have to be reauthorized periodically, and you know, this is a process. It's something you have to keep qualifying for. Um, I will say, in my experience with patients, it's not as nearly as hard for them to qualify for something like this as it was to try to get like Medicaid. All right, so let's talk about Medicare coverage. It's the largest single payer of healthcare services in the United States because the federal government has statutory and regulatory authority over services. What this means is somebody may actually charge one price for a healthcare service, therapy, whichever, but Medicare is like, well, listen, we're only paying this, and then that's pretty much it. Sometimes they'll send a bill out, but you can talk to a lot of people in their own private practices how they've, they adjust their prices with Medicare because they know they're not going to get the full reimbursement. This influences, other insurance plans. Kind of how we heard in that meeting a few days ago, how it was Humana, those kind of, they always kind of follow suit with Medicare and what Medicare does. So whenever Medicare makes a change across the board, a lot of private insurances all also make this a thing. Again, so eligibility for coverage, you have to be at least 65 years old, have to be a U.S. citizen for at least 10 years. You had to pay Medicare taxes for at least 40 years, or a spouse who did, and permanently disabled even if you're not 65. So, you don't have to be 65 if you have that permanent disability. So Medicare Part A. Let's talk about it a little bit more. Beneficiary will have experienced an acute medical crisis requiring hospitalization, followed by a lesser level of inpatient care skilled nursing facility. So you get this time frame, and you'll learn this a lot when you get into practice, especially if you go into a skilled nursing facility. It's normally about 21 days. And then they readjust or re-examine or reassess to make sure that you're still needing services. After that 21 days, most of the time you can get up to 100, and then anything after 100 is pretty difficult to do without switching insurance providers. From going from Medicare to Medicaid, and that takes a whole lot of liquid assets and really draining accounts and stuff that's extremely difficult to do. Hospital benefits or they cover the acute illnesses, diseases, or surgical care, but typically just for a few days. That Medicare's push is to get you out of the hospital because it's so daggone expensive. Get you somewhere else where it's cheaper. Hospital and skilled nursing benefits include room and board, medically necessary professional services like us, but they have to meet program requirements, and that's pretty much like our say when they do the evaluation, or not our say, but the OTR's evaluation, saying that they they need this. All right, so let's talk a little bit more about Medicare Part A. When they no longer need services, or they reach their goals, or they've exhausted their benefits, they've gone past that 100 days, they can get additional therapy and services, but at home. That's because it's way cheaper. Way, way, way cheaper to send somebody into the home for home health care for them to stay, even a day in skilled nursing. Last semester, we kind of talked about it, but it's over $300 a day for your typical nursing home, just one day. Think about how nice of a hotel room, or, gosh, for $300 a day, that's double Disney prices almost. So, keep that in mind when you're thinking about how expensive healthcare is. Copays and other out-of-pocket expenses are part of the plan. Those change. $20 normally for specialists or primary care, or $50 for specialists. It just really depends on the year. The stuff changes a lot. Hospice care is covered completely through Medicare, which is a pretty cool perk that, later in life, and if you're needing hospice or palliative cares, those things are covered. Skilled nursing is covered for up to 100 days for rehab. Remember, told you about that 100-day rule. Every now and again, you can kind of argue it, but it's almost a losing battle because it is so difficult to try to get, if you do win, you normally only win a few days, so they can help. It helps the family get things ready at home a little bit better. So if you have a family member who are ever in a nursing home for the short term. Remember, this is a short term thing. 100 days is pretty much as long as short term gets. Then be watching the 100 days, because they're going to start coming after, trying to get you switched over to different insurance plans and stuff. So it's a big ordeal. All right. So Medicare Part B, diagnostic, therapeutic, and preventative medical services, DME, prosthetics, orthotics, all that kind of stuff falls under Medicare Part B. Beneficiaries pay roughly about 25% of the costs. So this is like, it's not 100%. It's about 75, sometimes a little more, a little less, depends on the person. This covers services by independent OTs, PTs, speech, outpatient services in hospitals, skilled nursing, rehabs, doctors' offices, therapy offices, home health agency. This is Medicare, people. This is where a lot of people were getting nervous, because remember, it was Medicare Part B patients that were seeing that reduction in payment. Again, they're going to find a way to work this out. They always do, but nothing to freak out over, but just kind of keep it in mind when they say that there's a decrease in payment overall for OTA services, how much that encompasses. Some limitations and challenges, copays, and the need for Medicaid gap policies. Copays can be expensive for people that are, just living off of, Social Security after they reach that age, or, relying on Medicare. And, copays can get expensive, especially if you have a lot of doctor's visits. Then Medigap policies are the, let me pay, some more, or get a different policy here that will help cover the gap that Medicare does not, whether it be Part B, Part A, whichever. So the prospective payment system, this is now PDPM. We talked a little bit about it last semester. Remember, that is the payment-driven, patient-driven payment model. And then there's PDGM, is the payment-driven group model. Those, remember, they kind of say, here is what you get. That's pretty much it. This is how much therapy you can give them for this amount of money. Make it work. And that's really what is happening. So, these kind of things is like a pendulum. It swings back and forth, and it'll swing back the other way. It always does, always has, because it has to, because these services are needed. It's already started to swing back our way in a major way anyway. So, all right, so let's talk about, this court case here. It was Jimmo versus Levis. It was a change, the eligibility for Medicare services. Previously, you had to show progress or improvement in order to stay at a skilled nursing home and have home health care. But what it found is that, this idea, and I want you guys to write this down, make sure that you keep this in your notes, this idea of what's called functional maintenance. What maintenance therapy is you might not be going in to necessarily reach an increase in a goal. Your goal simply might be to keep them from getting weaker, to keep them from losing anything else, that are losing levels of independence. This absolutely helped a lot, because functional maintenance are showing no progress. They used to just not reimburse it, because they're like, what are we even doing here? But they realized that, having no decline is just as important sometimes as making progress, because you're keeping the person from getting any sicker or any worse or less independent, which in turn, when that person does get to that level, it's more expensive. So they're like, hey, if we're able to kind of prevent this or maintain what they have now, that's better than having them go into a nursing home for 100 days. Let's do this. So, it was a big deal. Let's watch this real quick video.
I was here alone for 4 days, helpless. I couldn't move, drink water, couldn't do anything. I just laid here, starving and scared to death. I said, I guess I'm a nobody. At 50, they diagnosed me. I accepted it, said I'll keep going as long as I can. I remember when my legs gave out and I lost the use of my right arm. I could feed myself, brush my teeth, and that's it. But I never cried. I was so busy fighting to stay alive. And I'm living a life I love, even though I am bedridden, because I love my bedroom. I love it. I see everything I did around me. When I was young, I would paint and draw. I look around and I say, that was my last painting over here. And every night I say to God, thank you for my bedroom. I wake up happy, I go to sleep, and I wake up again, and I am alive. Judy Stein saved my life.
Okay. So you can see how it changed things, from being able to say, like, her condition, she has a debilitating disease that will eventually take her life. It's terminal. But when you're talking about keeping her, as independent as possible, safe as possible, there's people coming in and checking on her, even, take OT out of the mix altogether and just talk about like home health aides and the need for things like that. Um, it was massive. It was such a huge deal to keep these people safe. All right, so let's talk a little bit about Medicaid. This is joint federal and state programs, and criteria is extremely complicated and it changes all the time. And every program changes state to state. So when you hear about Medicaid, it's a state insurance, funded, and it's got federal backing, but it's different state to state. Individuals need to satisfy federal and the state requirements in order to, to qualify, being a resident, immigration status, U.S. citizenship, all these things. They're moving toward HMO type plans, which is away from fee for service type plans. Um, Trying to get there. It's not quite got there yet. But concern for the spouse remaining in community because of the spin down provisions. What this means is keeping the spouse or caregiver, whoever, in the community and able to kind of help pay, because this is being paid for with tax dollars. Um, Keeping that balance is very important. It's kind of a perk with Medicaid that somebody that is a normal caregiver is able to go out and work because they have insurance. They might be able to get somebody in the home. So there's this new thing called the therapy cap. This is part of the Balanced Budget Act in 1997. It was placed limitations on OT, PT, and speech therapies, but it has been deferred numerous times. But in 2018, it was under President Trump's administration. A bill was passed and was completely eliminated and signed by the president and put in. So there's no therapy cap anymore. It used to be a massive deal because they said this is it, like we're capped off, but that's completely gone now. So good, you're coming in the field in a great time. So let's talk a little bit about the Affordable Care Act. This expanded Medicaid coverage to a lot of people. Not all states have implemented this expansion. West Virginia did. So, that's something cool to keep in mind. Currently, it's under discussion in Congress that they might do some, big changes. Nothing crazy has happened. The biggest thing with the Affordable Care Act was the mandate that was appealed under the Trump administration as well. Affordable Care Act has done a lot of expanding Medicaid coverage, but it's still extremely expensive. Or left insurance is still extremely expensive, which was kind of what the plan was. We'll talk a little bit more too in person about why what successes, what failures it had. One of the biggest bases that it was based on is that, or that it was founded on, was that young people would sign up, and young people don't go to the doctors. So that's how it was going to be funded. A huge chunk of the funding, and young people just didn't sign up. They just would rather pay the tax that was on it. It's not on there now, that penalty. They would just rather pay it because it was cheaper than trying to buy insurance. So that's what happened, and it kind of fell on its face in that aspect. But other than that, it did expand Medicaid coverage, which has been wildly successful for our state. It's extremely, extremely expensive for our state, but it did expand coverage. The functional reporting requirement. Federal programs incorporate specific reporting using G codes. We will talk about G codes more in class, but they're just a specialized reporting code. You don't need to know a whole lot for that, but just know that they use G codes for outpatient reporting. So some models for advocacy theories. I know we talked a lot about theories. I'm not going to talk a whole bunch about them, but there are some. We have the empowerment theory. This emphasizes supporting individuals and organizations in developing the skills to advocate for themselves, teaching patients to and companies to advocate. Listen, we're providing these skills. We need to be paid for them. Stop cutting our stuff. Blah blah. We can't do it for this. Those kind of things. So advocacy is huge. And then strength-based advocacy. This emphasizes that people and organizations are capable of changing growth. They can serve as their own experts, and that the problem, not the person, organization, is the focus of the attention. So literally not focusing so much on to advocate for themselves, but advocate that this is an issue. So systematic strategies for advocacy. You can use advocacy mapping to incorporate things, near-term outcomes, long-term outcomes, impacts, necessary conditions, things to do, activities. It's when they say advocacy mapping, what they're meaning is come up with a plan. So this is why, this is the problem. This is how we're going to do things. This is what our short-term outcomes would be, our near-term, long-term outcomes, and impacts on people, real people. These things are very important. Some other ways you can advocate is engaging and mobilizing the public. Get the public involved. Their voice matters. Coalition buildings, engaging decision makers like lawmakers, reform efforts, policy monitoring, which is why I preach to you guys, stay a member of WVOTA and AOTA after you graduate from school, because you literally have teams of people fighting for your jobs and reimbursement all the time. And it's really not that big of a fee. And then the therapist roles. What's our role in advocacy besides staying engaged with your state and national associations? Our therapists have responsibility to advocate for policies that assist their patients. If we hear of something that's going to be really good for our patients, especially if you hear AOTA backing it or WVOTA backing it, it's probably a good thing. It's really trying to keep our jobs as high paid and as populated out there as possible. And it's going to help keep our patients getting our much needed services. Some strategies include get data. If you do this many more people will get services. If you do this is how much it will cost. You really, when you go talk to anybody that is going to be a lawmaker, senator, House, governor, whoever, you need data and how much it's going to cost. That's really going to be huge. Again, these educational efforts for legislators and clients, making sure that they are aware of what the impact of a certain thing is going to be on somebody, and then helping patients and clients learn to advocate for themselves. Like, just they're not helpless, teach them to advocate for themselves and what they need in their services. And then again, communicating with legislators, making sure that they are aware that we're here. This is why we have that State Hill Day in the spring too, that we're going to go to in February, to advocate and show them who we are, put a face with the career, not just what is occupational therapy. We educate them what it is, why we're important. Don't leave us out of bills. Add us to this. If we can help here, help here. So a lot of people don't know what OT is. You have to teach them. All right, so that was our public policy chapter. Again, there's a case study at the end of chapter 3 there. Make sure that you have that done and turned in by midnight tonight. If you have any questions, just reach out to me. It's no big deal. Send me an email. I might not respond right off the bat, but I'll try my best. We're going to go ahead and move right on to chapter 6. If you need to pause this video, take notes, send me an email on that so you don't forget. That's fine. Just don't forget that case study that's due tonight by midnight. All right, so chapter 6, culture, ethics, and elder abuse. All right, so some attitudes toward aging. Attitude can be defined as a belief with an evaluative component. Might be a reason why that's highlighted. Just hint. I would probably write that down. Positive attitudes towards aging can support positive aging. We talked about that a little bit in chapter 1 and 2 on keeping people, positive about what the aging process is. There are some negative attitudes like ageism. We're going to talk about what ageism is. It's more or less discrimination against older people. Older adults may themselves have negative attitudes toward later life. I would say the majority of people I have that are older or coming toward that age do have a negative outlook. They don't want to become older. So you need to educate them too on, the positive things of becoming older. That listen, it's okay. Age is a number. Let's move forward. Attitudes can be changed through educational interventions, and then caution needs to be exercised, though, that individuals who do not experience positive aging are not marginalized. You don't want to use other patients or other examples of, you could have this, you could have dementia, but you don't. It's individual. Don't point out other people's flaws or disabilities or whatever to try to make their aging process sound better. That doesn't work. It normally just makes people mad. So culture and the intervention process. Culture affects access to care and willingness to use services. We talked a lot about that last semester across different cultures, if they're willing to use services, how trusting they are of services across different cultures, as well as do they value healthcare overall and healthcare services, and the need and recognize the need for them. That's going to equate to how many outpatient clinics there might be, or home health services, or whatever in the area. Cultural groups are affected by disabling conditions. It's different across culture groups. There's some specific examples we won't get a whole lot into, but understanding that, someone might have a disability in one culture, it might not be as seen as a big deal in another culture. Some cultural competence requires you gaining knowledge and understanding. I'm not saying you have to go out and know every culture and everything that's important to those cultures and stuff like that. That's not what I mean. I mean just being sensitive that people come from different cultural backgrounds and using that in your practice. You don't want to go in and shut the door right off the bat on therapy services if you insult them by something that you just simply did not know. So knowing how to, engage in that process is important. For example, if you have somebody who in their culture or their understanding is they don't get up till 9 o'clock, don't go in their bedroom at 7 in the skilled nursing facility and ask them to start doing things, because that's against their culture. You've already shut the door. Any kind of progress you were going to make, you just threw it out the door. So make sure that you are keeping on top of that kind of thinking, that you may. Now, I'm not going to say you're going to know that right off the bat, but if they express the concern to you that they don't like that, it goes against what their beliefs, their culture is, back off. Don't push them to do that. Work when their time. You're going to get better results anyway. So some ethical concerns later in life. Care must be given to attend autonomy, non-malfeasance, beneficence, and distributive justice. We talked about those terms many, many times in other courses, so I'm not going to rehash those to you guys, but if you don't know what they are, make sure you go back and check them out. Decisions are sometimes made on the basis of about the benefits of old age. So, making sure that you're aware of their beliefs. Um, some common issues that involve both over and under treatment of the individual. You may have a situation where someone is way too helping, and the patient gets this idea of learned helplessness, like they can't do anything for themselves. That's over treatment. Under treatment is they're not getting enough, which you think would be more common, but in my experience, overtreatment is just as common as undertreatment. People want to help people; it's like a natural thing. Everybody's like, "Oh, I love people, I want to help," but they help too much. I was guilty of doing it with my dad. Whenever he had a stroke, I had to learn to not help him as much, and I've been doing that stuff for years. Whenever he had a stroke, um, teaching other people not to do it, and then here I was doing it. It's very difficult. Um, One thing here, though, is that therapists must make ethical decisions related to function, such as whether a person is safe to drive. It's not always us. You can get the doctor involved if you need to with something like that. But if someone's like, "Do you think I'm safe to drive?" I don't know. We should probably talk to your doctor about that, or break it down somewhere where we would. Like, do you think I'm safe to get in and out of the shower? No, you're not. Your balance is terrible. We need to get you some more equipment in here in order for you to do that safely. So no, you can't do that right now. And then you document something like that, like educate a patient to not transfer independently in and out of the bathtub, recommended new equipment, those kind of things. If, like I said, if you don't know the autonomy, non-malfeasance, beneficence, and distributive justice, real quick rundown of those is autonomy is the right to self-govern. Um, Non-malfeasance is do no harm. Beneficence is do good. And the distributive justice is treating everyone the same, making sure that you're giving equal resources, those kind of things. It's across the board. Those should just be a quick reminder, refresh, but I'll throw those in there for you guys so that way, if you're just listening to a lecture, you can keep up. So elder abuse is roughly 1 in 10 older adults experience some form of abuse in any given year. Abuse takes a number of forms, including neglect, sexual abuse, physical abuse, financial abuse. The most common of all these, take a second and think about it, what you think it might be. But the most common is neglect. It's sad. I've run across it tons of times in my career, and it's really, really sad. But it's very prevalent. Abuse is seriously underreported, in spite of laws in most states that require healthcare professionals to do that. I want to say this as clear as possible. You guys are mandatory reporters. Absolutely. If you see something, you have to tell someone. Period. That's just the way it is. There's no way around it. It doesn't matter whose feelings you hurt. You are a mandated reporter. You have to tell somebody. It very well could be the difference in life and death. I have called APS. I probably 20 or 30 times in my career um, to get someone help because you're there for the patient. It's so important. Even if they're not your patient and you notice something in a household, you're there to treat a granddaughter or whatever, and you notice that there's neglect or abuse or whatever in the home to another person, you are mandated to report it. Okay. Some of the factors guiding your reporting decisions. Examples, illustrations of utter abuse, like you actually witnessing the abuse. One is signs like bruising. You may not see the abuse itself, but you see after effects like bruising. And then also being aware of what risk factors are. Indicate the possibility of elder abuse, like the risk factors of they live alone Are they small? Do they have somebody that's coming in that's much larger than them as a caregiver that could overpower them, or somebody that's in charge of their finances and all of a sudden now they don't have money for food, those kind of things. You have to keep that in mind. There's a lot of different screening instruments out there. All you have to do is Google them, and it's like a quick form you can fill out, and it'll help you decide. If you can't decide yourself, talk to your OT, talk to your supervisor, talk to a nursing supervisor, talk to the rehab director, whoever that you need to talk to make sure you're making the right decision. But you do have to report it to someone. Some of the other risk factors here are advanced age, lower income, ethnicity, reduced functional capacity, like they're just unable really to function. Problem behaviors or lack of family or friend presence in the home. There's nobody really looking at it. It's just that person and maybe a caregiver. Those kind of people are at huge risk. Some risk factors for the abuser. The person has a mental illness or emotional stress or struggles from alcoholism. Those kind of things. You have to be aware that if the person who you think may be the abuser is, or the caretaker there, a risk factor for them to become an abuser are some of these things, or that they're dependent on the money coming from the client. These are all things that are huge risk factors for somebody becoming an abuser. And then some environmental risk factors are social isolation. They just don't have anybody coming in. It very well could be neglect from that. And then shared living arrangements. One person getting more, help than the other. So there's some approaches to abuse. Okay, there's 7 major ones, and definitely keep note of these. You have it as a social problem, a geriatric syndrome, family violence, an aging issue, criminal action, human rights violation, and public health concern. Now we're going to talk about each one of these individually over the next couple of slides. So we'll go ahead and move on to those, but make sure you write these down, take good notes on these. So a social problem. This is where, you're going to be working with a patient or see it, that the receipt and investigation of reports, assessment of client status and service needs, arrangement or provision of services to treat harm or prevent its recurrence, and obtain, this is the big part, the reason it's highlighted, obtainment of legal interventions. Okay? The geriatric syndrome, they have a definitive diagnosis, typically using some type of a screening tools, but to identify, establish signs and risk factors, and clinical management essential methods. Okay, we'll move on, but the big one there is identify, establish signs and risk factors. Your next approach is the aspect of family violence. This focuses on empowering the victim through information support and safety planning, as well as holding the person accountable. If you're not holding the abuser accountable, what approach are you really doing? Seeing it as an aging issue. This is advocacy for the rights of vulnerable elders. Make sure they know they have a right. One thing that you guys need to keep in mind is if a patient has capacity, meaning they are able to make their own decisions, they have the right to tell you no, that they do not want to work with you. They do not want to do occupational therapy today. Now, that might not mean that you don't have someone who is stubborn. You go back and check with them later, or you find something that will motivate them to come. If they're flat out refusing you, screaming, no, they're not coming, and they have capacity, they have the right to do that. Now, you may sit there and say, listen, I know that therapy is not the most fun thing. It hurts when we move your arm, blah, blah, blah. All of that is important, but saying, I know, this is not that great, but if we don't move that arm, you're looking at a much larger issue like a frozen shoulder, and then explain that to them, trying to convince them. But, again, they have the right to tell you no. So always keep that in mind. Next is as a criminal offense, protect society, maintain order, enforce law, control crime, and punish perpetrators. A human rights violation is another approach, which where you get government action in and enact legislation. Seeing it as a public health concern, again, you have the government make an initiative. to protect the public if it's seen as a public health concern in your area. Each one of these offers a different approach to abuse and finding out what the problem is, how we can best solve it, those kind of things. But when you are addressing abuse, I want you guys to keep a holistic mindset. It might not be one strategy or another or way to approach it. You need to know what you're talking about when you are reporting abuse. You need to be able to clearly state what you saw, what you hear, anything like that. They're going to ask you all these questions, but keeping in mind these different approaches that we talked about and keeping a holistic mindset. It might be a social problem, it might be an aging issue, it could be a geriatric syndrome. Whichever approach that you're talking about, a holistic intervention is the best. So that's actually it for us today. If you guys have any other questions, please, to let me know. Send out an email, whatever you need to do. So make sure you guys get those case studies due in tonight. One of them, remember, is chapter 3. One of them is chapter 6. Both due tonight by midnight. If you have any questions at all, feel free to give me a shout. Sign up for some stuff for Enlightened Living Day, and I will see you all on Monday. Have a great and safe weekend.